Hello, everyone. Welcome to Perspectives in Professional Psychology. Really appreciate you joining us this evening. I'm really excited about our discussion today. We have Dr. Bob Foltz with us, a clinical psychology faculty member with our PsyD program in Chicago. Welcome, Dr. Foltz.
Thank you. Thank you very much. It's a pleasure to be here.
Tonight we're going to talk a little bit about your kind of an area of expertise for you, and in particular, a book that is going to be coming out soon that you are the author of, called No Method to Madness. So, could you tell us that No Method to Madness talks a little bit about and kind of offers a critical perspective on psychiatric treatment for youth? Can you tell us a little bit about what drove you to write a book like this?
Yeah, so I'll give a little backstory about the journey that got me here. When I was a student in my undergrad studies, I started working in psychiatric hospitals.
Hmm.
And at first, I was just captivated by the condition of schizophrenia. I worked with adults back then and spent quite a few years working as a mental health technician in psychiatric, and for the most part, acute settings. I was typically in admission units or acute care units for severe psychiatric conditions. And in that position, you get to spend hours of the day just hanging out with clients. So in those discussions, now I was getting my psychology degree at the time in undergrad, and I was having conversations about their symptoms, their experiences, but I was completely being educated about the medical model and how the reason people were getting hospitalized is that they were non-compliant with their medications and that they needed to get back on their medications. They needed to
Yeah.
get stabilized on their medications. But as I was having these conversations hour after hour and day after day with clients, the message I started getting from them was that they really didn't like taking their medications.
Yeah.
And and I started to kind of filter that through like if I have the flu or something and I could take medicine for relief of all the agony of having the flu, all the pains and vomiting and all the problems, I would take it and I would be compliant with that medication to get that relief. And it struck me that as terrifying as the condition of schizophrenia is, people were not wanting to take their medications.
Yeah.
So that started to challenge some of the paradigms that I was being educated on. So as I came to Chicago, and so I was doing that for years. And as I came to Chicago, this was back in 1990 when I came to Chicago for graduate school. I kept working in hospitals throughout my graduate education. And I was hearing the same thing. I was
Yeah.
working with adults diagnosed with schizophrenia for the most part. And then probably in the mid 90s, a colleague called me and said, "Hey, Bob, do you want to work in residential treatment?" And I was like, "What's residential treatment?" So I took the job. I was a clinician in residential treatment settings with troubled youth. And what I found there really started to motivate my research and my scrutiny over this literature because in those settings, it is not uncommon that young people are being medicated with many medications at the same time, which goes well beyond any established evidence base. And I was hearing the same thing from the young people that I don't think the medication is helping me. It makes me feel weird. I don't like it. And or they'd be sleeping all day because of being over medicated and too sedated. So because we were in this era of evidence-based treatment, I started to ask, I started to review the literature and I started to ask questions and I started to be a little disruptive in that environment. And, as training to become a psychologist, when you start pushing on the medical model, there's a bit of kickback. So I was dealing with those politics as well. But I spent 15 years as a clinician and then administrator in residential treatment settings. And I guess my wheelhouse was really the severe psychiatric conditions. I didn't have as many kids under my supervision with like disruptive disorders. It was more like the psychotic disorders, the bipolar disorders, the severe trauma reactions.
Yeah.
And those kids were just getting handfuls of medications. And I kept wondering, this is not what the research is telling us should be helpful.
Yeah.
So anyway, so years and years of that work. And my first publication was in the early 2000s, because by this time I had started really accumulating a lot of literature about what is supposed to work, what's not working, and how these things are supposed to be working, and what we really understand about these different disorders. So then fast forward to 2009, I started teaching here at the Chicago School. And one of the courses that I've had the opportunity to teach for so many years now is pediatric psychopharmacology. And it's allowed me to stay at pace with all the new research coming out.
Yeah.
And, it's what I love reading. It's what I love researching. So I've had the opportunity to just dive into this literature for many years now and really scrutinize it in a way that my whole goal in writing the book was to lay out the research of what we know, examine our prescription patterns and our diagnostic patterns, and then challenge the field to really think more creatively about optimizing the outcomes for our young people. Because even the best evidence says that these medications only really provide temporary relief.
Yeah.
But we are keeping kids on these things for a long, long time, well
Yeah.
beyond any evidence base. So
Yeah.
when I kept getting hit with this information for years now, decades, I was like, you know what? It's time I write all this stuff down, and decided to do the book.
It's interesting. The story you share kind of aligns with some of my experiences as well. I'll share a couple of them. So I did my internship in Chicago, and my first rotation was inpatient psychiatry. And I didn't have a lot of experience with inpatients at that point, but we would have folks kind of come into the unit, and a lot of times um, they were in the unit because of an episode that was triggered by being off of their medications. And I even remember a psychiatrist telling me, because we had several people come in who had been diagnosed with bipolar disorder. And I don't remember the exact number, but he says it takes 3 or 4 or more inpatient hospitalizations before someone with bipolar disorder finally decides to become compliant with their medication
Wow.
schedule. And when I had conversations with these patients, a lot I'd ask them, why is it that you're not taking your medication? And for many of them, the side effects were worse
Mhm.
than the symptoms they experienced when they weren't taking it. And
Yep.
there's some really profoundly negative side effects for a lot of these medications.
Yep.
And then my next rotation was in the emergency department doing psychiatric triage late nights. And it was the same thing there. So we'd have people come into the emergency department having some sort of acute episode. And a lot of times it was medication related. And it wasn't always because they hadn't been taking their medication. Sometimes it was because they had started a new medication and had a really adverse reaction.
Yep.
And to your point about the evidence base and kind of what you've seen in particularly in kids and adolescents, that's pediatric psychology is my area of specialization. And I can't tell you how many kids I've seen in private practice who come in, their parents bring them, they're experiencing these significant behavioral disruptions, emotional dysregulation. And we take a look at their medications, do the full psychosocial history. And a lot of times I'll ask, well, how has the medication been working? And many, many times the answer is it doesn't seem to be doing anything at all. And then my follow-up question is, well, how long has your kid been on this medication? Sometimes it's years.
Oh, yeah.
And
Yep.
it always kind of just triggers the question, why on earth would the prescribing physician continue to prescribe this medication when they're getting reports that hey, my kid's not getting better. Sometimes my kid is getting worse.
Yep.
The behavior's gotten worse since he started or she started the medication, but the answer was still the same. Well, they've been on it, and we just refill the prescriptions.
Yep.
So I've had very kind of direct experience, and I think a lot of psychologists have with what you're describing. And one of the things you touch on in your book, and I think you started to touch on this in your last answer, is some of the the flaws in our diagnostic system and in our treatment system, where is it that you see the biggest disconnect between the diagnosis aspect of what we do and then the actual clinical need in children and adolescents?
Yeah, just in response to your own experiences, it
Yeah.
reminded me my doctoral dissertation. So I did 2 years of training in a state psychiatric hospital with adults. And
Hmm.
in my request in doing that training was to work in the back wards. I was literally the wards that I had clients on were literally a couple of units in. So I had to go through locked units to get to my clients. So for my doctoral dissertation, I created a project to interview patients on their experience of being medicated. Now,
Mm.
when I embarked on this project, I thought, I mean, medication use is so rampant, there must be other studies out there to then add on to build upon,
Yeah.
to push the research forward. It had not been done.
Wow.
And it was stunning. And in that sample, it was relatively small. It was like around 50 patients I was able to interview. But one of the experiences, in addition to the side effects they talked about, there's a phenomenon in the literature called deactivation. And
Mhm.
as a result of exposure to not just antipsychotics, but a couple of like the antidepressants seem to add to this a little bit too, but primarily the antipsychotic medications are characterized as deactivating their reactions to the symptoms. So to
Mm.
carry that concept further, my interview pulled for some of this material. So I sat down and these patients were floridly psychotic, but I just engaged them in the conversation. And the material I got was phenomenal because what it turned out to indicate was virtually all of them continued to experience their psychotic symptoms, but
Yeah.
reacting to them less. So for society, it's advantageous, right? They're not
Yeah.
being disruptive, they're not yelling out on the street corner and stuff like that. But to quell their terror, it was not working.
Yeah.
So from their experience, it kind of makes sense of like, why would I go through all these side effects when it's barely helping me anyway?
Yeah.
Um, so it's really stunning. And so to your diagnostic question, so I'm guessing some of the people in attendance are clinicians. So we all know that the newest diagnostic manual came out in 2022, the text revision. Um, and the original, the DSM-5, came out in 2013. And soon after that, they released the inter-rater reliability scores for these diagnoses. Um, and what that really demonstrates is very few of our commonly accepted diagnoses meet the threshold for acceptable inter-rater reliability. So
Mhm.
simply put, for those that may not know, imagine we were all sitting with a client, and if we had high agreement on what that diagnosis was for the client, we would have high inter-rater reliability. And the threshold for acceptable reliability is zero point 0.6. It's a kappa score. It's a
Yeah.
statistical measure. Um, but many, I mean, I should say it this way, very few of our diagnoses meet that threshold. Many of them are in the 0.4s, 0.2s. There were some that were just so poor, yet they included them in the DSM. So when we first start with seeing the overall flaws and failings of our diagnostic models, then when we step back and to understand the challenges with young people in creating a diagnostic picture, because one of the things that's been proven over and over in the literature is there is poor temporal stability in the diagnosis of young people. So
Yeah.
what I may sit down and do a diagnostic interview with a young person, and 3 months later, they may present very differently just because of developmental issues and
Yeah.
life experiences and all sorts of other things. So I think part of what one of the challenges for the field is that we assume that there's like hard science that we need to anchor ourselves to with the DSM, when in
Yeah.
fact, even the DSM itself, in the part of the DSM that nobody reads is the introduction section.
Yeah.
But even they admit that these disorders are far more porous than they previously understood,
Yeah.
meaning there's tremendous overlap. The clinical picture can change. It can change depending on who the kid is talking to. So, and that's true for adults as well. Um, so I think we need to be skeptical consumers of even though the DSM is kind of the guide we have, I think we need to be skeptical consumers or critical consumers of the information and just know that it is a work in progress.
Yeah.
Another example, ADHD. This one is one of my soapboxes. So I have video in 1998 of this expert consensus panel talking about the diagnostic criteria for ADHD. Members across this panel agreed that the diagnostic framework for ADHD is not adequate. It's flawed. And their explanation was, but we really don't know what DSM-5 is going to bring us. Now, that was 1998. The diagnostic criteria for ADHD barely moved at all between DSM-4 and DSM-5. It has been decades now, and it hasn't been modified. So decades ago, they knew it was flawed. They've had decades to modify it and refine it and make it more precise and sophisticated, and they haven't done so.
Yeah.
So
And
I think when we see it kind of from the 10,000-foot level, we have to just be humble and say, this is the guide we have, but there are a lot of problems with it. The other thing I would add, and this is kind of a contextual issue. So when I was going through grad school, we spent a lot of our time focusing on kind of the function and purpose of symptoms.
mhm.
And like, these behaviors are disruptive, they're maladaptive, they're challenges, but I was trained to see them as coping strategies, even though they were maladaptive. They were efforts by the person to manage the stress they're dealing with
Yeah.
and function as best as they can. But we've lost that framework, and we've, I think, drifted towards this checkbox of, do they meet the criteria? And if so, then let's go to our evidence-based treatments and pull out the manual and start doing our treatment. So I just, in general, I think people need to recognize that the DSM is a very flawed document.
Yeah.
It's what we have, but we need to just embrace it with its failings. But then also we need to step back and appreciate that there is a very valid framework to understand symptoms as unmet needs. And if we took that approach in looking at young people, I think we would approach the work in a different way.
Yeah, I think that's a fascinating perspective. It's so interesting. I think that when you talk about the poor inter-rater reliability, and I think almost any psychologist has had this experience. I know I've talked to colleagues and they feel similarly. When you go through graduate school, you feel like you're going to come out and you're going to have this core set of skills that will allow you to engage in, sophisticated, accurate diagnostic procedures, come up with a diagnosis and drive a treatment plan from that that's evidence-based and have great outcomes. And I think to a certain degree that's true. But any psychologist who's kind of gotten into the diagnostic process, when you're pulling together assessment data and you start to try to look at it, conceptualize the patient, and come up with an adequate or accurate diagnosis, it's way more complicated,
Yeah.
right? And a lot of times you're taking your best guess based on the data you have and what seems to check boxes, to your point, within the DSM. And then you go to, the diagnostic criteria for ADHD, and I've felt this for a long time. It is inadequate. I don't think it adequately captures what we need to capture to effectively diagnose a kid or an adult who has ADHD. But then you think about that, and then you start to try to tabulate how many kids have been put on a medication regimen, who have been given stimulants or, multiple stimulant trials over time based on a diagnostic category or diagnostic criteria that is deeply flawed, and that the people responsible for organizing and reviewing and vetting the research associated with the DSM diagnostic criteria themselves acknowledge is inadequate and flawed. And it really feels like an injustice, a travesty for kids.
Yeah. And ADHD is one of those categories. I think because it's so prevalent and so kind of easy to meet the criteria. But this is one question that anybody that's had me in my psychopathology course, they know walking out of the class at the end of the semester, what word begins every diagnostic criteria for ADHD? And the answer is often. often fidgets, often gets out of their seat, often
Yeah.
interrupts. But the key to that, I mean, fine. So I always make this point with my students too. There's no doubt that kids are challenged within our academic environment. There many kids are disruptive, bouncing off the walls. That happens. So I'm not indicating that it's not a problem. We can call it whatever we want.
Yeah.
But when the diagnostic criteria begins with often, often for me, if I meet with
Yes.
Billy every week and he does the same thing each time I meet with him, that's often. But for a
Mhm.
parent, often is a very different definition. And for a soccer coach and for a teacher. And if we don't adequately conceptualize and contextualize the frequency of those behaviors across collateral supports, we're missing it. And the other thing, this was one of the changes in DSM-4 to DSM-5. Most diagnoses require that the symptoms create an impairment or a level of distress.
Yeah.
But a change they made for ADHD is that the symptoms must reduce the quality of work. So
Mhm.
that really gets easy to meet that threshold. I mean, I have
Yeah.
days myself where I'm distracted or tired or whatever else, and my quality just isn't the same as it was yesterday.
Yeah.
So those kind of issues, and again, I love digging into the weeds on this stuff. So, but most people are like, well, we know what the criteria are, and we kind of have a clinical impression of what ADHD is, and they move down that road. But then to your point, then they go to the literature and pull out the practice guidelines. And those practice guidelines are largely written by the American Academy of Pediatrics in terms of ADHD, the
Yeah.
American Academy of Child and Adolescent Psychiatry, or the American Psychological Association. And all of those frameworks promote the idea that combined treatments get the best
Yes.
results.
Yep.
Now, those studies, there are a couple exceptions, and this is some of the what fueled the energy behind my book was to really deconstruct those studies to point to what the outcomes really prove to be. But to just specific to ADHD, so in 2019, the American Academy of Pediatrics guidelines came out for ADHD. And in 2018, there was a meta-analysis released. It was, and the authors claimed to create the most comprehensive review of the use of stimulants ever completed. And they did it for the purposes of informing practice guidelines and policymakers and clinicians. So that was 2018. In
Yeah.
2019, the guidelines came out and they did not include that meta-analysis. So here's one of the conclusions of the 2018 meta-analysis, that in their comprehensive review of all the research on stimulants, they could only justify well, they chose methylphenidate.
Mhm.
Adderall had similar outcomes, but a higher side effect profile. So they said, our recommendation is methylphenidate. But they said we could only justify the use of methylphenidate for 12 weeks. Beyond that, the research
Wow.
drops off a cliff. So, but if you pull out the guidelines from the American Academy of Pediatrics, they don't include this study. So one of the things I like to do is contact the authors and ask, why didn't you include this study? And the person that responded to me said, we weren't aware of it, which I take with a grain of
Yeah.
salt because they
Yeah.
included other research by the lead author of that 2018. So the guy wasn't like an obscure clinician researcher.
Right.
He had published a lot on ADHD and they happened to miss this
Feels like a
comprehensive.
big miss.
Yeah, a big miss. But you know, everybody can't scrutinize the research like I do. So they pull out the practice guidelines and they follow the guidelines from the American Academy of Pediatrics, which means kids stay on these medications indefinitely, expecting positive outcomes when
Yeah.
the research doesn't support it.
Yeah. Yeah. And, potential long-term side effects,
Yeah,
just it's troubling to say the least.
yeah,
On that point, when you think about kids being on medication a lot, I know that a lot of times the issues that lead to the conversations about getting a diagnosis and potentially getting on medication arise through problems at school. Sometimes it's a combination of, disruptive behavior at school and disruptive behavior at home. But when that happens, I think parents feel a lot of pressure to, especially after the diagnosis, get that diagnosis. But once they have that, there's a lot of pressure to get your kid on medication. I think in some ways parents feel compelled sometimes. And as we've been discussing, that's not always indicated from the evidence base. Could you talk a little bit about what some of the risk of using psychotropic medications as a first line approach are, and if there are any alternatives, maybe you could talk a little bit about that as well.
Yeah. And so in thinking about this, part of my first reaction to the question is that I believe providers of therapy, whether master's level or psychologists, carry a certain burden with this because we have succumbed to this medical model of treatment. So
Mhm.
I know colleagues today that believe that we have established chemical imbalances, that the science supports, whether, depression or schizophrenia, bipolar disorder, that there's some science out there that establishes a chemical imbalance exists.
Yeah.
And despite the lack of science to support that, if you start at that point, so if somebody comes in and somebody is diagnosed with ADHD, but you've read the guidelines or you have this belief that it's a frontal lobe problem or it's a deficit in executive functioning, it's a neurological condition, you start already with the assumption that there must be a pharmaceutical agent to utilize during this
Yep.
process. I
To
think
rebalance the imbalance.
yeah, and I think we have set ourselves up, and part of it, I mean, we can't be experts in everything, and some people are just, they'll devote their studies and everything to psychodynamic theory or
Yeah.
CBT or other disorders, whatever. But when we just kind of blindly accept the idea that the science is more robust than it is, we set kind of a glass ceiling for what our own capabilities are. And I'll share, I guess, kind of in the reverse. So over the years, one area of training that I received years of training on was the psychotherapy of psychosis.
Mm.
It's virtually not taught anymore. It's hard to
Right.
find people that still practice it, but it set the foundation for me to be willing to work with someone with or without medications and with tremendous distress going on in the room.
Yeah.
Um, so my own private practice, I over the years have just had, I would say the majority of my clients were people that had been through the system. And the majority of my clients were also like adolescents and young adults, but I worked with some older adults with more severe conditions. But these young people had been through the system, had limited success, and just felt like things weren't working. So they wanted to start with someone new. They realized that I would work with somebody not on medications. So they come in and start with a blank slate. And I think most clinicians would push back on that approach because if somebody is really depressed, even I have colleagues and students that are convinced that depression is a chemical imbalance,
Yeah.
despite the fact that the science doesn't support it. So trying to reshape that paradigm is really one of our biggest challenges, I think. And even so, even with the antidepressants in young people, the American Academy of Child and Adolescent Psychiatry in 2022 came out with their revised practice guidelines for depression in adolescents. And their primary recommendation, or in terms of medication, was fluoxetine or Prozac. So they summarize all the research to guide their decision. And ultimately, it comes, well, I always like to ask people how many kids they would imagine were studied, but
Mhm.
you would hope it's thousands, right? And
Yeah.
you would hope it's thousands over many months, if not years.
Yes.
It's less than 200. And most of those studies are like 4 to 6 weeks. So when they summarized all of, and I have all this in the book, just summarized, but so 4 to 6 weeks, less than 200 people. And then the other piece, the other dimension to looking at this kind of research is when a drug is FDA approved for a particular condition, in this case, Prozac for depression in adolescents. Other drugs that want to come on the market and medicate depression have to compare themselves to the established accepted standard of Prozac.
Yeah.
So newer drugs like Cymbalta and other antidepressants came out, and in their effort to get FDA approval, they had to run these trials comparing themselves to placebo and Prozac. In those studies, so there were less than 200 receiving Prozac that justified the use of Prozac. In those other FDA trials that ultimately didn't get approved for depression, there were hundreds and hundreds of kids on Prozac that did not outperform placebo. So the preponderance of the evidence is
Yeah,
that Prozac doesn't
doesn't
outperform
work.
placebo. Yeah. And if it does, we have to expect it to be short term. So like when I'm working with somebody that's medicated, well, first, adults, I just never push back because adults get to make their own decisions and everything else.
Yep.
But with young people, I always have in the back of my mind, what's the plan going to be when it stops working? Because part of that means helping support the parents because things can get complicated, helping educate both the parents and
Yep.
the young people and the school staff and everything else. Because when the benefits begin to diminish, all sorts of other resources and services need to be activated to provide the
Yeah.
necessary supports. So I think as clinicians, we need to, again, appreciate where our strengths are and appreciate where the limitations of the other disciplines are, because they can offer something in the short term, thinking specifically about medications,
Yeah.
but we have to expect that even the science tells us that it's short-term benefits.
Yeah. It's interesting too. I want to go back to something you touched on early in our conversation, and that was kind of the functional nature of symptoms. And I think that's something that gets missed so often, right? People think of medication as, like you said, fixing an imbalance, that's going to be the way forward without the work in
Mhm.
some sense, right? But there's this whole the maladaptive coping conceptualization suggests that there are environmental things going on that are impacting the symptom presentation. I often think of all of us walking around with kind of an invisible toolbox
Mm.
of adaptive or more productive coping skills. And some people's toolbox has a lot in there. Some people's
Mhm.
has just one tool, right? It's a hammer or it's a screwdriver. Um, and so that's what I think is so critical to think about in terms of what the alternative is, or what the side by side is for a short-term course of psychotropic medication. The
Yep.
focus has got to be on kind of understanding the environment and what the triggers are for the symptom presentation, what's in the adaptive coping toolbox, and how do we help kind of build insight around that? How do we build skills? Because you're right. I mean, even if the medication does work, that wanes over time, many
Yep.
times.
Yep.
And if you're relying on a single treatment approach like a psychotropic medication, you're going to get stuck in a loop, right? So, well, the
Yep.
Prozac isn't working anymore. Let's see what else is in the formulary that I can prescribe that might get you back to where you were
Yeah.
feeling good during the previous course of treatment. And then
Yeah.
it becomes that kind of continuous long-term cycle of psychotropic based intervention without thinking about how to build that good coping skills toolbox for the individual.
Yeah. And in this, you're hitting a key piece because the science, the research tells us that these benefits diminish. But because of that initial phase of perceived effectiveness, we get into an attribution bias. And then we think,
Mhm.
well, it worked early on, so let's increase the dose, or let's
Yeah,
add something to it, or switch something, or now they're on 3 medications. And there's this
yeah,
never-ending pursuit to get back to that point when in fact the science doesn't support it. We get really passionate about chasing what worked at the beginning. And the other piece, I mean, we've all seen the image of Bronfenbrenner's ecological model, and that's the framework. I mean, I was just talking to my students earlier today about it. We should think, regardless of what our theoretical orientations are, and many people just drift one way or the other, but
yeah,
we should start with a systems foundation.
absolutely.
And especially for young people today, there are so many infiltrating pressures
Yeah,
on these different systems around them that it takes us right back to the function and purpose of these symptoms or these
yeah,
maladaptive behaviors. Even calling them symptoms is, but it's just their best efforts to cope with a very complicated world out there.
yeah.
And we need to think in terms of that Bronfenbrenner model.
I couldn't agree more. And I think there's kind of three pieces that I always ask about that I think unfortunately often get overlooked when you just kind of jump to medication as an option. And I ask this of parents, every parent of a kid that I see, talk to me about the sleep patterns.
Oh,
Talk to me about the dietary patterns.
yeah.
Talk to me about the physical activity patterns, because there is a substantial amount of research supporting the impact of high quality sleep, regular physical activity, and a high quality balanced diet on how we're functioning emotionally, behaviorally, and socially.
And there, yes, there is a mountain of research coming out on these topics. And in fact, just last week with my class, and I'm clearly not an expert in this stuff, but the microbiome has such
Yes.
a massive impact on our thoughts, feelings, and behaviors. In fact, I showed my students a video that details that the gut bacteria, I love some of these statistics. The bacteria in our gut outnumber our human cells 10 to 1. So
Yeah.
we are far more made up of these little bacteria, and they have direct influence on neurotransmitters,
Yeah.
on and it accounts for almost 80% of our immune system functioning,
Yeah.
which is stunning because the other thread that I've been paying attention to lately in the literature is the role of inflammation. And
Yes.
inflammation seems to be tied to almost everything. In fact,
Everything.
one of the colleagues here in Chicago sent me an article. Dr. Fogel, who teaches our biobases and psychopharm track, sent me this article that there's even an anticipatory inflammation reaction
Yeah.
from the environment. So our body is so sensitized to defend against threats, and we can stimulate an inflammatory response just in the approaching threat. It
Yeah.
doesn't even have to be ingested or something. It's
Yeah.
just in our environment, which is amazing.
Yeah.
But that's thinking then holistically, and that's stepping out of our silos and
That's right.
really becoming integrative in how we're looking at, like you said, sleep is so critically important. I mean, I had a student years ago who did a dissertation that demonstrated um, that if you miss, for a teenager, if you miss 1 hour of sleep a night, let's assume they're supposed to get 8 hours. If they miss 1 hour 2 nights in a row, they begin to demonstrate symptoms of ADHD.
Yeah.
So then the research came out. We often say, oh, I'll catch up on the weekend, I'll get the sleep I need. But the research actually shows that those sleep missing the sufficient number of hours actually keeps affecting you up to 2 weeks later. So we don't catch up,
Yeah.
we have underappreciated those core things: exercise, healthy sleep, and healthy diet.
Yep.
Coming
They're the
from,
foundation of total health,
yeah.
right?
Yep,
Physical,
exactly.
social, and psychological.
Yep.
Yeah, I've always been fascinated by the gut microbiome. I got my degree in health psychology and behavioral medicine, so we were kind of soaked in that throughout my
Wow.
graduate education. And I think a lot of people don't understand that one of the biggest drivers of inflammation is chronic stress.
Yes.
And so that's another kind of area that has to be looked at and
Yep.
considered and maybe addressed before choosing a psychotropic option for
Yep.
intervention.
I just heard a study or a report about a recently released study last night on the news using hair. They were looking at an adolescent sample, looking at hair and the
Yeah,
presence of cortisol in the hair as a representation of exposure to stress,
yeah,
because cortisol is released and as a strategy to deal with stress. But
yeah,
just hair samples begin to indicate a certain trend towards emotional or behavioral problems.
yeah.
So we're just
That's
taking baby
fascinating.
steps, but it's so awesome that we have to integrate all this stuff.
And you might know the exact number, but there's a large percentage of this all of our serotonin produced by the microbiome,
It's
correct?
virtually all of it. It's
Yeah,
the estimate. In fact, the video I showed the other day is 95%, and I've seen estimates down to 90%, but 90 to
yeah,
95%. It's virtually all of it. That being said, other critical neurotransmitters are also cultivated in the gut microbiome. So GABA and glutamate are heavily influenced down there. And the production of serotonin as a secondary effect also affects the behavior of dopamine. So we start seeing these typical targets but the microbiome is really influential in how they behave, how they influence the rest of our systems.
Yeah. So you've talked a lot about some of the shortcomings of the medical model when it comes to, identifying effective evidence-based treatment approaches for youth in with mental health conditions. What's the way forward? I know, we've just kind of been touching on some of that, but in your book, you talk about integrative counseling strategies. What does that look like? And is that kind of your thought for a solution to some of the challenges you see?
Yeah, yeah. It's really kind of reestablishing, or I guess bringing up the stuff that was so meaningful to me in my training.
Hmm.
So first, one of the key elements that unfortunately, despite decades of awareness, we are still under appreciating is the role of trauma.
Yeah.
So, I mean, I read a book, I mean, literally 20 years ago called The Boy Who Was Raised as a Dog by Bruce Perry. It is a game-changing book. It is, and his work, Bruce Perry, and then we've got Bessel van der Kolk and all sorts of experts just making amazing contributions to the field. But we don't really approach our diagnostic process through the lens of trauma, and we
Yeah.
should. I always tell my students, rule out trauma first and then do your diagnosing, because trauma reactions can look like emotional dysregulation,
Yeah.
periods of anxiety, sleep problems, concentration problems, unstable relationships, paranoid ideation, even psychotic symptoms. So the DSM acknowledges that people could have hallucinations, but the ICD-11 just broadly says you can become psychotic from trauma experiences. So if it's really a trauma reaction and we're calling it disruptive mood dysregulation disorder or conduct disorder, or pick the
Yeah.
diagnosis, we're going to go down the wrong road of treatment, and people are going to be frustrated, outcomes are going to be diminished, and
Yeah.
they're going to be stuck in the system far longer than they need to be. So we have to start with a trauma lens. And I I consistently, and this is from my development as a clinician, but I think we have to really embrace a strength-based approach. So with that, I had exposure to the people that created this model called the Circle of Courage, and it's based on indigenous science, but they have it's tried and true. It's been tested all over the world. They've done trainings, and it just mirrors and integrates really well with all sorts of multicultural methods of intervention and just ways to perceive health and wellness. So the Circle of Courage is made up of four components, and it's creating belonging, which is a sense of connectedness and safety
Yeah.
among relationships, a sense of mastery, which is developing competence, a sense of independence, which is developing responsibility, and then a sense of generosity, which is developing compassion, empathy, and kind of a contribution back to the world around us. And if we focused on those strategies rather than just suppressing symptoms, because our
Yeah.
current outcome measures typically look at reduced symptom
That's right.
severity or symptom presentation. And I always say, an absence of symptoms is not health. We have to pursue
Right.
it. So when we look at our intervention strategies to cultivate strengths and resources for an individual, rather than simply seeing a successful outcome as reduced symptom presentations, I mean, ultimately, if we boost all of the skill sets we're looking for, the symptoms are
Hmm.
going to go down.
That's
I mean,
right.
just by default. So,
Yeah.
but we've got swept up in this medical model for so long. And the other thing I would say, just in terms of the path forward, um, it, our field is not the only place that's become very polarized. So I would say that we need to really work to build bridges across different disciplines. I
Yeah.
mean, like, people that are listening to my discussion probably think I'm very like anti-psychiatry, but they have tremendous skills to bring to bear to helping someone. And the more collectively we can work together, the other, like working with young people so much, like occupational therapists are just critically important and underutilized in my view.
Yeah.
I mean, schools and different like health centers use them, But like in terms of collaborative care at an outpatient basis, we should be doing a lot more work with occupational therapists. They just have another skill set that we don't typically incorporate and can really
Right.
be advantageous. So I would say be strength-based, really focus on cultivating the strengths and, appreciate the distress that's going on, but we have to build these strengths, approach it through a trauma-focused lens, and really work on collaboration and building these. Because, I mean, to that point, being in Chicago for decades now, I've established a really valuable network of psychiatrists that I trust. And when a family comes to me and says, Billy doesn't want to be on his medications anymore, what are we supposed to do? Because as a psychologist, I can't prescribe, I can't make recommendations one way or the other. So I'll connect them to somebody that I trust that I've worked with many times to get people off
Yeah.
medications. And then it's phone calls, it's back and forth, but it is an ongoing process that if they're going to come off an antipsychotic, for example, I know that I may need to see them more frequently for a while.
Yeah.
But that's just part of the plan. It's not a failing. That's the other thing it reminded me of when we were talking before about, when you have to increase the dose and add more medications. Ultimately, we start using the phrase treatment resistant. And that's a disparaging term towards clients, but
Yeah.
it's not, it's the science tells us that the treatment's going to stop working. So
Yeah.
we're blaming the
We put
patient.
it on the client.
Yeah, we're blaming them,
Something
but it's,
intrinsic to them
yeah,
is causing
yeah.
resistance. Yeah.
Yeah, it's
That's
so
interesting.
frustrating. But I mean, it's really about building back to Bron from Brenner's model. It's about creating a community of support. When we think
Yeah.
about circling that client with resources, we put too many eggs in the medical model basket.
Yeah.
It's a basket we need to have, but there are a lot of baskets out there.
Yeah. Where we get into trouble and have historically is when we work in isolation,
Yep.
right? When we're not talking, when we're not engaging in collaborative care for the people that we see. Because to your point, it would be easy, I think, to demonize psychiatry based on some of what we've seen. But they have incredible training,
Yep.
incredible skill set, um, incredible experience, but without the psychological side of it, right? Without the doctor in clinical psychology or counseling or the OT or the speech, um, you're missing some piece of it. So just like that kind of the holistic view of health, there's the biological, psychological, and social aspects of total person health. If you think about health from that perspective, you need multiple professionals to create that kind of system of care
Yep.
to address all of the major components of what it means for an individual to be healthy. If you have one clinician, one practitioner with a particular set of skills that's trying to address the whole thing, some aspect of that treatment is inevitably going to fall short of providing the total
Yep.
kind of holistic treatment that that person needs.
Yep. Yeah. What you're describing is the framework of consilience, like bringing together different disciplines to arrive at the direction, the truth for the pursuit.
Yeah,
So, we don't have a monopoly on all the facts. We need to bring in
absolutely.
other experts. And the other, I guess, dimension to this is when we consider how the systems have been created, like even the psychiatrists that I refer to and trust, they're limited. Their time availability is
Yeah,
so compressed. We
yeah,
have painted them into a corner. And when they can only offer 15 or 20 minutes of contact time with a client, it's probably not enough. But
no,
that's how the system has now been funded and constructed through
yeah,
reimbursements and everything else. So they do have that skill set, but when we have an hour to provide, contact with a client, we can generate a wealth of information and a
yeah,
wealth of understanding and all of these other pieces of information that we can bring back to a treatment team to
yeah,
help drive decision making.
yeah. And you touched on this, but maybe to even look at deprescription, right?
Yeah.
Which
So
probably doesn't happen enough, but it's an important avenue for actually treating someone.
yeah, I have a chapter of that in my book. And I tread very carefully because as a psychologist, I
Yeah,
over and over say these are not recommendations. But what I have done is pulled the literature on deprescribing. And I got to tell you, One of the psychiatrists that I've known for many years, his name is Christopher Balanci. He's based out east and has done just amazing work with young people. He's a brilliant psychiatrist. He helped develop the framework for deprescribing. And it's basically in its infancy because people are really not trained to deprescribe. I mean, I should say it's kind of inherent in their work because they do have to take people off medications, but it's rarely to the point of getting them permanently off medication.
Right.
It's like, well, we got to switch this one. They're having a side effect, so we'll discontinue that. But it's not in the framework of thinking successful treatment is when they're finally off their medication.
Yeah. When they're not reliant on.
Yeah.
Yeah.
So, but there's great work out there about deprescribing, but it's really limited.
Yeah, that's interesting. And I think I saw a research article not too long ago that was looking at psychologists with prescriptive authority, and that is kind of one of the benefits that we see for prescribing psychologists is that they're more likely to deprescribe
Oh, wow.
than other medical professionals.
Great. Well,
Yeah.
that's good. Good news.
Well, I know we're coming up on time, so maybe we'll close out with asking you about when you look to the future, when it comes to mental health care for youth, what gives you hope? Are there any promising trends out there?
Um, I have a lot of concerns. I think one of the things that does give me hope is more people are receiving more care than ever before.
Yeah.
So there's greater access. I mean, just having worked at the Chicago School for so long, I know that there are just really talented clinicians entering the field. That really makes me feel optimistic. But when I start to think the bigger picture of the impact of social media, the suicide rate, that despite all of our evidence-based treatments, the suicide rate for young people isn't coming down.
No.
Rates of depression and rates of anxiety are going up. And part of that makes me think back to the idea of kind of collaboration. We need to be reaching beyond our field to capture all of these different phenomena that are impacting young people. Because I know the talent is out there to help support their recovery and their mental health wellness. But we're facing a lot of obstacles. So I think when we think systemically and just in this broader healthcare system across the country, we've got to try to tackle some really complicated issues. And I think social media is at the top of the list, and not just because of recent events, but I mean, it's been years now. There's a great book called The Anxious Generation, and he's, I believe, a social psychologist, but he really plots very clearly the increase in anxiety and depression as a result of young people's access to technology. And technology is not going anywhere, but we need to figure out, and we should really help drive this effort, figure out where the healthy boundaries are.
Yeah, completely agree. I think the research is pretty clear. There's a strong correlation between the rise of social media and the increased rates of anxiety and depression in youth.
Yep.
So it's a scary time, but there is hope.
Yeah.
Right. There are things that we can do. So, Dr. Foltz, it's gone by fast.
It has gone
It's been
really
a fantastic conversation.
Yeah.
Thank you so much for joining us. Maybe we'll, if you're okay with it, we could take a few questions if
Sure, that'd be
anyone
great.
listening in has a question. So if you would like to ask a question, you can drop it in the chat. We'll give folks a minute.
And while they're coming up with that, one of the things I was going to share, just thinking about the trauma lens. So my students and I surveyed all of the APA accredited programs a couple of years ago, all APA accredited doctoral programs. And so we asked them, how many of the programs require a course on trauma theory or treatment? And the results were stunning.
Yeah.
Just 5% of the programs.
5%.
Yeah, and it results, I have this graphic up here. So 5%, and it represents just a fraction of, I'm looking for the number of actual students covered, but it's just a drop in the bucket. So 5% of programs require a trauma course. Yeah. Now, people can become trauma informed, of course, outside of their graduate coursework, but
Sure.
it should be a foundation.
I agree.
Now, thankfully, the Chicago school offers it as a requirement,
Yeah.
as we do psychopharmacology, but even that one is less than a third of programs, all doctoral programs, less than a third require a psychopharm course.
That is really stunning.
Yeah,
And given what we know about the research on trauma, I'm surprised it's not even an accreditation requirement for the
right.
curriculum.
Yeah. Well, it has now, since that study, we have
Yeah,
gotten some traction and exposure, and it's now being discussed as like one of the standard requirements. So hopefully
fantastic.
soon.
Well, Dr. Foltz, we haven't had any questions come in.
Okay.
So I'll just close by,
Oh,
oh,
wait, I
we do
see a
have a
raised hand.
question.
Okay.
Brianna?
Hi, sorry. I didn't mean to interrupt you guys. Good evening, everyone. I want to say congratulations, Dr. Foltz, on your upcoming book. My question is just pretty short and simple. What are your thoughts on how possibly untreated trauma in childhood ends up developing into adulthood? And basically, when parents want to toe between, I don't want to necessarily overly medicate my child, but I also know that there needs to be some type of resolution to their behaviors.
Yeah, well, so great question. So the unresolved childhood trauma, I mean, the literature, we could start with the ACEs study. So the Adverse Childhood Experiences study asked people about 10 different adversities that they could have experienced. And the way the questionnaire was did this adversity occur before the age of 18? So based on if it was a yes, no, if it was yes, you got a one. And based on that research, then they were surveying, collecting health data on people. The average age was 56. So there was almost a 40-year window of time between if the adversity occurred and the health outcomes that they were looking at. And the research is just robust. I mean, and the more trauma exposure you have, so if you have, it's typical, I think the figures were like 2/3 of people have at least one adversity. The higher exposures were upwards around 4, which represented only about almost 17% of the ACEs sample. But once you hit 4, you really start to see a lot of complicated physical health and emotional behavioral health and negative interpersonal outcomes. So this kind of speaks to a concept called allostatic load, that we all have kind of this threshold of what kind of burdens we can carry. And it seems like 4 adversities in our lives before the age of 18 really seems to be a tipping point. And there's individual variation in that, but unresolved, untreated trauma really can have a major impact. And then to your other question about when parents are really struggling and they're just, wanting to utilize medications for something, I would approach that with the assumption that, yeah, it might work in the short term, but what are we doing in the meantime to make sure we've got the resources to support this kid once the medications stop being effective?
We had a question come in the chat. To what extent are expressions of depression or self-harm among youth influenced by peer pressure or social trends?
It's a great question. I don't know the hard numbers on it, but it's a huge influence. Part of the dilemma or the problem with social media is so much of it is just fabricated,
Yeah.
and people can quickly, their self-esteem, their sense of self-efficacy, everything that they're trying to aspire to improve can really quickly become diminished as a result of social media. And the other piece about teenagers is this kind of concept of impression management. Adolescent years are just critically dynamic in people trying to figure out who they are, how other people perceive them, and everything else. And it can be a really hostile environment out there. So that can quickly take its toll. So depression, anxiety, self-harm, all of those are just inherent components of somebody struggling to find themselves, feel accepted, feel like they're on a path towards success.
Yeah, I often think of the quote, I think it was Roosevelt, comparison is the thief of joy.
Mm,
And
yes,
social media is a lot of manufactured
yes,
comparison, unfortunately.
absolutely. Yep.
Yeah. Um, please forgive me if I mispronounce your name, but Shay, do you have a question?
Oh, yes. Good evening, um, Dr. Lance. I don't know if you can hear me.
We've
Yep.
got you.
Yes. Thank you all so much. It's been very inspiring. I'm a military chaplain, and I am jumping into psychology because what I've found is working with most of the soldiers, you deal with the spiritual aspect of their health, their mental wellness, but then you find that there's still a big gap. So I was like, okay, how can I bridge this gap? And I thought of psychology. So I'm coming in freshly from that chaplaincy background. What advice can you give someone like me with zero background in psychology, just trying to uh, go through the prereqs to get on the program? What one advice can you give me to inspire me for this great step?
It's a great question. I would say, well, one, just start digging. There are so many good books out there, and with military experience, so many good books just related to trauma. So that is, even if trauma is not your ultimate pursuit, it lays such a foundation of our understanding of how experiences can impact us. So I would start there. But the other thing I always encourage students looking at graduate school and wanting to pursue a career in psychology is just understand that it is an unfinished field. And if you maintain your passion for the topic and a sense of curiosity, that alone is going to carry you a good distance. So when I first started in the field, I had no idea where I wanted to end up. And working then with adults diagnosed with psychotic conditions, then landing working with troubled youth, it has become my career. So I've just kind of weaved my way through it. But yeah, just follow your passions and stay curious.
Thank you.
We've had a couple more questions come in, Dr. Foltz. This one is from Kieran. Kids often need support right away, but at the same time, there's a risk of rushing into a diagnosis or medication. How do you think professionals can strike that balance between rushing to support and potentially misdiagnosing and improperly medicating?
This is another major problem in the field. And I'll start by just saying it's part of the system that we've constructed. So for someone to receive services that are using insurance, if you're using insurance to receive counseling services, therapy, whatever, it requires a diagnosis. Now, that's a major problem because I've had phone calls with insurance companies that said, well, you know what? The diagnosis you're using isn't severe enough, so we're not going to reimburse for services. And I'm like, well, I'm trying to avoid a more severe condition. So it doesn't make sense to me. But there are clinicians out there that offer like sliding scale and pro bono services, but I would really recommend getting in early. So, sometimes we just kind of wave off somebody's distress and say, oh, they're just going through a time right now, or they'll be fine. But those are the moments to really start paying attention, because some of the stats, this is interesting. 50% of all psychiatric diagnoses are applied by the age of 14, 75% by the age of 24. And symptom presentation usually begins 2 years before the diagnosis is given. So these are general stats. I mean, it could vary individually. But that means first off, it means it's a young person problem. Second piece is when symptoms are starting 2 years in advance, we've got a lot of opportunity to get in there and make changes. But our system of reimbursement and all these complications don't really support that. But it means getting creative, finding resources in the community, and finding clinicians that offer sliding scale or pro bono work, those kinds of things can really be advantageous, and leveraging the educational system. So we place too much, teachers and school staff wear too many hats, but they are kind of a hub of being able to activate resources. So they could offer counseling services, they could set the bar or set the ball in motion to get evaluations done and those kinds of things, which could create a baseline of understanding how a particular kid is doing. So it's there's a lot of moving pieces to it, but getting in early and getting resources moving is really important.
We have the questions are really coming in now. Maybe we can take two more and just have some quick hits and then close out. Would that be okay, Dr. Foltz?
Sure. Yep.
Okay. So Aaron asked, what are your thoughts on the literature that states that certain diagnoses, such as schizophrenia or bipolar disorder, have to be treated with medication when considering or factoring in the idea of deprescription?
That's a great question. And that really pushes back on this paradigm that has been in place for years and years. In fact, when I was a graduate student, I was routinely told that you could not do therapy with a person diagnosed with schizophrenia unless they were effectively medicated first. I heard that over and over and over. So when I embarked on my dissertation, I thought, oh, there must be a bunch of articles that support this. It doesn't exist. And in fact, there's a researcher out of the University of Illinois. His name's Marty Harrow, who's done long-term evaluations of people on medications diagnosed with schizophrenia. What he shows is the longer that someone stays on medications, the worse their outcome is. So I think part of it is, now that being said, I've worked with psychiatrists in the Chicago area that are absolutely willing to go through that deprescription, even with somebody diagnosed with schizophrenia. So it is about cultivating those relationships and also laying the foundation to say, look, we've got other services that we can utilize while we're going through this process. And even if they don't get completely off their medication, I've worked with people that were on just baby doses of a medication that their side effect profile is way lower, their functioning improves, and their symptom control is just solid. So there are a lot of creative ways to approach it.
And then we'll take this one as the last question. This is from Sasha. How does labeling a child with a psychiatric diagnosis influence their behavior throughout childhood and then long-term through adulthood? Is there a large difference in cases where the individual is effectively treated? Thanks for an amazing, informative discussion. That's a great question.
Yeah.
Just the being labeled, how does that impact a kid?
Well, so I'll start by saying I've got some dissertation students doing research on adults, the experience of being diagnosed with ADHD, but from the adult perspective. And when they finally received an ADHD diagnosis, there was a sense of relief because it gives them a handle, kind of this label to hold on to and figure out, okay, at least I'm not alone, and at least there's some understanding of what I'm going through. But the other thing that becomes critical in this process is what they believe about it. So if somebody comes to me and says, you know, I've asked patients, it's always amazing to see the response when they come in and they say, I'm taking this medication and this medication. And I'll say something like, well, how long do you want to be on it? It's like, what? Like, what do you mean? I have the option not to be on it? Because if people are of the belief that it's genetic, that it's a chemical imbalance, that it's, you know, neurologically driven, then you've hit kind of a threshold, and it takes a lot of shaping and just contributing to their educational process about what we understand about these disorders. So I've seen it go both ways. I've seen some people say, thank God I finally understand what I'm going through. But then I've seen other people that say, I don't want this to be who I am. And how do I get out of it? You know, how do I take this? The other thing is, generally speaking, our diagnoses and everything else are supposed to be strictly protected. The other layer we have to appreciate is all this collection. You know, technology is here to stay. And the, you know, access to artificial intelligence and everything else, that's a whole other discussion we could have. But when we start absorbing health records at a mass scale, we also have to consider where the privacy boundaries are. So I just throw that out as a caution, because especially with young people, when we know a child, when I was working in residential, the idea, if they were diagnosed with pediatric bipolar disorder, it was just assumed they were always going to be bipolar, rather than revisiting and reevaluating 2 years later and saying, is this still what we got? But we need to do more of that too. We need to appreciate the developmental progress that somebody is making, and what they may have been at 13 is not where they're going to be at 20.
No, radical developmental shifts over time.
Yeah.
Shouldn't assume they're going to be locked into anything. Right.
Right.
Yeah.
Yeah.
Well, I apologize to those questions that we didn't get to, but very much appreciate everyone's interaction and engagement. Some really great questions there. And Dr. Foltz, thank you so much to you. I learned a lot tonight.
This is a
Great
pleasure.
conversation.
Yeah, I enjoyed it. Thank you.